Hello, all, welcome to Mnemonic. In today's topic, we'll be talking about calcium channel blockers. Let's get started. Then, calcium channel blockers, we'll be seeing under following headings like drugs, mechanism, pharmacodynamics, like which actions and uses, ADR, and other things. Coming to drugs, we have amlodipine, nifedipine, nicardipine, nimodipine, nitroglycerin, isodipine, isradipine, felodipine, cilnidipine, clavadipine. These are all dipine drugs. They are belong to dihydropyridines groups. Then we have non-dihydropyridines such as diltiazem, verapamil, and etripamil. This is the newest. Coming to its mechanism, as the name says, they block calcium channel. You should know there are three types of calcium channels: L type, T type, and N type. So calcium channel blockers block L type calcium channels, and these DHPs they block more vascular than cardiac. These L type calcium channels they present in vascular smooth muscles and cardiac tissues. Then this depends mainly block vascular things, and diltiazem it's as 50-50, like balanced effect on both heart and vessels. And verapamil and atropamil they're more cardiac, so they directly inhibit heart. So you'll have decreased contractility, decreased heart rate, and conduction. You're blocking in blood vessel, it leads to vasodilation. Coming to its uses, all of these are mainly indicated with the hypertension and angina, and not and we have a few exceptions where etripamil it is not used in hypertension. That is the only exception. Then coming to other uses except hypertension, we have Raynaud's phenomenon. Amlodipine is used in Raynaud's phenomenon and peripheral vascular disease, pulmonary arterial hypertension, hypertensive urgency. Tocolysis, nifedipine is used as a tocolytic agent, and as a topical agent it is used in anal fissure like a topical agent, and achalasia, and again PAH. Nicardipine is for hypertensive emergency. CSA means chronic stable angina. Then we have nimodipine. It is not used for hypertension, it is used only for subarachnoid hemorrhage. Then we have cilnidipine, which is used for diabetic kidney disease. Then for clavadipine, it is very it has very short half-life, that is almost 1 minute. So it is metabolized by estrase, so it has less than 1 minute half-life. So it is only used in acute severe hypertension, perioperative hypertension, urgency, emergency. Only in such conditions it is used. Coming to diltiazem and verapamil, they are mostly used in hypertension, angina, supraventricular tachycardia, AFib, A-flutter. And apart from stable angina, it is also used in unstable angina too. And coming to diltiazem, like nifedipine is available as topical for anal fissure, even diltiazem is available topical for anal fissure. And it is also used in HOCM, Raynaud's disease, PAH, achalasia, diabetic kidney disease. Then verapamil, this is very important. It is used as prophylaxis for migraine and cluster headache. It is also used in hypertrophic obstructive cardiomyopathy, mania, and DKD. Coming to adverse effect, there's peripheral edema, dizziness, flushing. All these are due to vasodilatory properties. And you should know gingival hyperplasia, it is more common with the CCBs, especially nifedipine. It is more common. And coming to group specific, dihydropyridines causes reflex tachycardia. They're causing vasodilation, so reflex tachycardia, and it worsens GERD. Coming with the non-dihydropyridines, it causes bradycardia and it worsens heart failure. And verapamil specific is constipation. This one is very important. And coming to other points, amlodipine has the highest half-life, almost 30 to 50 hours. Then nimodipine is used in SH because it is highly lipophilic. It crosses blood-brain barrier. And cilnidipine, it blocks entire calcium channel. That's why it is used in TKD. Then this I told clevidipine. And verapamil increases decoxin level because it is a P-glycoprotein inhibitor. Then etripamil, it is available only as nasal spray. So acute attack for PSVT, it is used as nasal spray. Then coming to this is extra ads. If you want, you can learn, or else it's okay to get. There is something called as Bell-Hassan ventricular tachycardia, also called as idiopathic fascicular ventricular tachycardia, also called as verapamil sensitive ventricular tachycardia, where normally for VTs there is lignocaine and amiodarone, but here verapamil is sensitive. This is very rare thing, Bell-Hassan. Then vasoreactive positive PH patients, we give high dose CCB. In previous slide I told about CCB being the treatment choice for pulmonary arterial hypertension. So only in vasoreactive positive patients. Next slide I'll show the management algorithm. Then Peyronie disease. This is the Peyronie disease where penis is curved because of this fibrotic thick plaque. Interlesional verapamil is used. It is off-label use. FDA approved uses this Xiaflex collagenase Clostridium histolyticum. So that is only FDA approved, like in medical management. There is surgical management too. Under medical management, this FDA approved. This is used as a off-label because it's cheap. And this is the management algorithm of PH. And this is where for vasoreactive patient we give CCD. Once you do all the tests and only when vasoreactor is positive, you do calcium channel blocker. Use CCB as treatment option. And coming to, you should know the difference between hypertensive urgency and emergency, and which calcium channel blocker is used. Urgency is where BP is more than 180 by 90 or 180 by 100, and emergency, like different guidelines is different cutoff, but they should be having target organ damage in emergency and no target organ damage in urgency. And during urgency we can give oral, not IV is not always necessary, and we give amlodipine or nifedipine extended release tablet. And for emergency, yeah, IV is required. We have clevidipine and nicardipine. And historically, immediate release nifedipine was available, and now it's contraindicated because it causes precipitous drop in BP that can lead to watershed stroke, MI, or death. Then this is one of the Viva questions they ask, like drugs causing gingival hyperplasia. We have CCBs, I told nifedipine most commonly, then phenytoin and cyclosporin.